Very warm welcome to all of our attendees today, and special thank to Daniel Taylor, an advanced practitioner here in the UK. Thank you so very much indeed for your time. And yeah, all of our participants are very keen to see our contemporary knowledge and assessment here in the UK and management of cervical radiculopathy in primary care. Um, if any of our attendee has any questions, please raise your hands and we'll love to answer whatever queries you have in your mind.
Yeah, thanks for having me today. Yeah, I've been asked to give a talk on cervical spine pain and radiculopathy. I work as a locum here in Bristol, and I work in a GP practice called Kennedy Way, and I also do some locum work for Connect Health, which are dotted all over the UK. I'm going to primarily look at how I manage neck pain and radiculopathy from a primary care point of view. So this is a bit of a summary of me and what I do. I think the biggest thing to pick up is the value of experience, and over time I've really begun to appreciate that a lot more. I think when we originally qualify from a very young time in our profession, we're asked continuously to follow the research, to take a very academic approach to our clinical practice. And what I'm certainly learning as the years progress is actually a lot of the time the experience trumps the research. And whilst we use the research to form the foundations of what it is we do and how we diagnose and treat in our general practice, I always think we should be using our experience to diagnose and treat as well, and that's certainly stood me in good stead. And hopefully you see that come through, and some of the limitations that do exist within the current literature. So I always like giving a bit of background in terms of neck pain. It's the fourth largest cause of disability. I don't know the third one, but back pain is the leading one. Then I think it's migraine. I don't know the third. So if someone wants to Google that and pop it in the chat, feel free to. Again, here in primary care, roughly 1/3 of all GP consultations is due to either back or neck pain. And again, if you look at the literature, it might vary. It might be a little bit higher. It might be a little bit lower, depending on where you look. Again, when you look at the costs to healthcare systems, it's quite significant. And if in one study, it showed that it cost the US economy over $87 billion a year. So kind of gives you a feel for actually how prevalent it is and the implications. Again, looking at the data, it can affect between 10 to 20% of the general population, and you tend to find it's more common in females than males. And again, we see it commonly with back pain, that there's a big biopsychosocial overlay, and you see that with neck pain as well, that these are risk factors. And again, commonly you see it more in people over their fifth, sixth decade onwards. So if again, before we get to the kind of diagnosis point of view, we need to know what neck pain, radicular pain is. So again, this definition I quite like. So we're looking at arm pain, numbness, paresthesia, and then more neurological features, so maybe muscle weakness as symptoms. In terms of causes, I always say in primary care, the common things are common. I'd probably say 99% of the cases that I see will be due to a common self-limiting cause. And the most common cause of neck pain, radicular pain, will be due to a disc, be it a disc bulge, a disc herniation, or some form of spondylosis. So whether there may be some hypertrophy to the facet joint or some degenerative changes to the disc, they're the most common causes. And when you look more down at the pathophysiology, you're normally getting some sort of inflammatory or ischemic response, which then drives a lot of these symptoms. And again, that's quite important when we're looking at treatments to offer. And I always very much reassure my patients, if you see neck pain and radiculopathy, it is incredibly painful, particularly in the acute phases. I always try to reassure them that these symptoms, generally, the vast majority of cases will settle naturally, and inherently there shouldn't be any need for surgery. Obviously, there will be a percentage of cases that may require surgery, but the vast majority will resolve naturally. So like I said, the common things are common. I'm going to give you 4 cases where these are cases that have happened over the last 6-7 years of my time in primary care, essentially where these patients have presented with what looks like musculoskeletal pathology to the neck, or radicular symptoms, which you would think are musculoskeletal pathology, and they're mimicking in that way, but ultimately they weren't musculoskeletal cases. And like I say, this is a small percentage of patients that do present with this. I think it's important we have a understanding of differential diagnosis. So I just wanted to give you a couple of these. These are live cases that I've dealt with in the past. So this was a young female that called our practice during the COVID-19 pandemic. And again, across the UK during this period, pretty much everything was converted to telephone consultation, and there was very, very little face-to-face contact. And she called up complaining with a 3-week history of neck pain and left arm pain. There was no trauma, no cause for it as such. And I put it down to most likely some form of MSK, disc, facet joint related pain, and advised her with some basic exercises and some over-the-counter medication. However, she called back a week later complaining of a new onset of weakness in the left arm. And she was also complaining of loss of sensation in that left arm. And in particular, from a functional point of view, she was struggling to lift objects, even reporting loss of movement in the shoulder. She had no other non-related MSK symptoms, so no chest pains, no fevers, and so forth. Obviously, it was very difficult to bring patients in and examine them during the pandemic. And so on that day, the second time she rang, I spoke with the on-call neurosurgeons, and we both agreed that she needed to be seen, and that she's most likely got a big disc that's causing the symptoms. And if we admit her, we can get her scanned. But interestingly, when we did scan her, it showed that she actually had MS, which was never on my radar at the point when I was speaking with her. And it's just something to be aware of. Obviously, she's now been diagnosed and she's got swift treatment.
Dan, thank you so very much indeed. That was fantastic. Okay. Very well prepared with the lots of research, and I'm hoping that we will have so many questions after that. Okay, then we've got a few questions here. Ifra Suhail, she said, my dad has chronic pain. What should I do? I think it's a very generic question. So if we have any symptoms, then we can answer better. Uh, what There are other questions if we have any. Dermatomes to examine if you wanted to differentiate, obviously, is C5, C6, or C6, C7. I think studies are more focusing on C7 radiculopathy are more common in than the other side, or unilateral rather than bilateral. So, what's your experience, Dan, in primary care? What you see most, right or left, radiculopathy or bilateral, or yeah, your take
Yeah,
on.
generally I see it's unilateral. I don't necessarily see more on the left or the right. I generally see it's unilateral. Um, I probably see more kind of C6. I don't know whether that's due to maybe the anatomy, and that's an area in the spine where um, the disc is maybe more prone to bulge or herniate. That would generally be my take on it, more unilateral. I'm probably a bit more concerned with bilateral because I'm then asking myself what's pressing centrally on the cord. Have I got a big disc there, or is there something else going on? Are they maybe myelopathic? So that concerns me a little bit more when it's bilateral. Whereas if it's unilateral, that's telling me there's some sort of maybe nerve root irritation.
Very grateful to Dan to coming on this session, and we're hoping that we will have your expertise in future again, with other pathologies, and especially when you're working in primary care setup. And I like the idea you said your experience then tells you much more than the evidences and research. You have your own wisdom on the background with all of your assessments and seeing patient day in and out. So thank you so very much indeed for your time again. Um, and all of the viewers, we have got Physio Guru website, and we will upload we upload our all questions and interactive the feedbacks there. So if you guys have any question, by all means do visit there and give us your other questions or feedback at on Physio Guru. So yeah, thank you so very much indeed for all of you attending today, and especially for Dan. Thanks for your time. Thank you very
Thank
much.
you all. Have a nice day.
You too. Thank you.
Bye.
Bye.